Sir, we are live in 3, 2, 1. Please start. So we are live.
Very good evening, all of you. My name is Satish Rama Joshilkar. I am from Zydus Life Sciences. Would like to welcome all of you on this evening called CLEARTalk. This is a scientific initiative, and this is one more facet of Unite Against Dyslipidemia. I welcome all the delegates and our today's eminent speaker for today, Dr. Sachin Patil, sir. He is one of the best faculty we have on board today, and would like to give a small brief introductory presentation about sir. Sir is MD DNB Cardiology Chairman and Consultant Cardiologist, Sachin Multi-Specialty Hospital, Kolhapur. He is Senior Faculty and Interventional Cardiologist known for complicated cases like LMCA, bifurcation, CTO, rota ablation, etc. He is a pioneer of radial angiography, radial, peripheral and complex coronary angioplasty in Kolhapur with more than 12 years of experience. He is a very prolific speaker, more than 500 talks to his credit. Without wasting much of our time, would like to hear from horse's mouth. I would like to call on Sachin sir to share his slide and start this presentation.
Yes, thank you, Satish, for that nice introduction. And let me share my PPT. Okay. So I welcome all for this CLEARTalk session. So this CLEARTalk session is all about bempedoic acid through the lens of clear outcomes trial. Basically, we all know now that LDL as far as low is better, and longer that lower is maintained, still it is more better. So both the aspects are important. One is a lower and longer, and different drugs, which as we can see here, what it proves in all is if you reduce LDL by 1 millimole, you will get approximately 23% relative risk reduction in cardiovascular MACE and deaths. So now this has been well proven all over the thing. In fact, as the time goes, if we see here in the year in trial, right, roughly 2 to 3 years means 24%. But if person continues and maintains this LDL for low more than 6 years, the risk reduction almost goes to 36%. That's substantially high. And that's why the management of dyslipidemia is high on priority, and statins are the first line of therapy. But there are some issues with that. One, do all the statin users achieve the LDL-C goal as per the guidelines? And second is, how to achieve that target if the maximum tolerated dose of statin is given and still we are not at target? So these are two concerns in our clinical practice. So let's address one by one as to, do all statin givers achieve the goal? If we see, the recommendations are very clear as per the 2019 that a very high risk patient should have a LDL less than 70, and a very high risk means those who are having a recurrent ACS or recurrent unstable angina or any vascular events, their LDL should be less than 55. And that has been a stark change as compared to the previous guidelines. The LDL goals are coming down and down. But the issue is, how many patients they do actually control this LDL-C? If we see from Da Vinci study that only 27.6% of the patient are actually receiving the high intensity statin in spite of they being deserve it. Now, why they are not taking is a lot of concerns about the patient, their perception, physician, and their own ideas about the dosing. But ultimately what happens, 30% of them are only on the statin dose. If we see very high risk patients where you have to prevent the second or third event, still only 37.5% of the patient receive the high intensity statins, and out of that only 22% achieves the goal. So that's too low. And that's why these patients keep on having the recurrent events. And that's why we should have something that, okay, whatever dose he is tolerating and we have given, if he is not achieving that target, what can we do? So how effective is this line of therapy? If we see, these are our garden variety of patient. Atherosclerotic cardiovascular disease like unstable angina, stroke, peripheral artery disease. Normally what we give is a high intensity statin. If we give high intensity, still it achieves about 50%. That's why it is called as high intensity. But if we want more, probably we can add ezetimibe, which can take it to 65, or we can add a bempedoic acid, which can take it to 65 to 70%. If we add both drug like bempedoic acid and ezetimibe, probably 75%. And if we add PCSK9, we can get almost up to 85% of the reduction of the LDL from what we have begun. Then familial hypercholesterolemia or this patient, obviously when we have a complete statin intolerance, obviously there is complete intolerance and you can't give statin. Still these drugs will be effective to an extent. So this just shows that how bempedoic acid can contribute in apart to the statin or without statin also, right? Here we know that those who adhere to the statin therapy for long, they get more benefit. We saw that 5 years, 6 years, from 22%, it grows up to 60%. And that's where we lead to bempedoic acid, first in a class LDL lowering drug. It has been approved to reduce uncontrolled LDL-C with a maximum tolerated dose. Whatever maximum is tolerating is taking, still not achieving the goal. What can we do? Add a bempedoic acid. Or mixed lipidemia, familial hypercholesterolemia, very high ASVD patient where the targets are really low and a single drug cannot achieve it. Or simply that patient can't take statin. We do see such patients in our practice who simply can't take statin. So for them, the bempedoic acid is a good drug and the dose recommended is 180 milligram once a day, right? So 1 minute, yeah. So what is this all about bempedoic acid? It is similar pathway as a HMG CoA reduction, but one stream up. It's like a RAS inhibitor where beta blockers or angiotensin receptor blockers are the lowest. Then before that, there is a ACE enzyme which can be blocked. Or before that, there are renin inhibitors who are also available once upon a time. So it's like one link above. So there in mitochondria in the liver, there is one enzyme called as ACVL1, which converts bempedoic acid into active drug, which stops this ACL or acetylcholinesterase conversion to HMG CoA reductase. And that's how it blocks the pathway. The beauty of this molecule and ACVL1 is that it is simply absent in the skeletal muscle. So skeletal muscle cannot block this pathway in the skeletal muscles, and that's why that is not possible to have a myopathy. So inherent safety, because most of the times myopathy has been found to be a limiting factor for taking the statins. So management of patient receiving this bempedoic acid, half-life is 21 hours. Most of the excretion is through the kidneys. But if there is a mild to moderate impairment, that's not a cause of concern. If there is a mild to moderate hepatic impairment, that's not a cause of concern. We can straight away give the full dose. We need to be more watchful if that patient has a uric acid levels or he is a known case of gout. Or if the patient is an elderly person who is taking a corticosteroids or fluoroquinolones, and then there is a history of tendon rupture. So some sort of skeletal complications, if he is there, then probably we need to be more careful. While if the patient is elderly, taking steroids or fluoroquinolones with CKD or ESRD, to be frank, and if there is a history of tendon rupture, probably we can't give this drug. Or when we give with simvastatin or pravastatin, which again increases the concomitant levels, we can't use. Pregnancy, obviously, we have not studied, and breastfeeding also we have not studied. So issue comes is, what's the data? Is it safe? Can we use it? So this is the latest data from ACC 2023 from late breaking trial that was published in NEJM. What it shows is that whenever these things are combined, and it has been studied for the reasonable safety. See, look at the number. It's almost like a 14,000 patients, and they have been compared minimum for 2 years. So these 14,000 patients, median follow-up was 40 months, minimum follow-up was like 24 months. So those who are statin intolerant, still it is, we see somewhere in 15% of the population, and still that prevents us from achieving the goal. There, this ATP citrate lyase, that is ACL inhibitor, bempedoic acid, stands the tall place. And because of the CV reduction, this has been approved as a lowering agent, and it can help us patients saving the life. What about this 4-point MACE? Is non-fatal MI, stroke, revascularization, and death, while secondary outcomes were, apart from these 4, cardiovascular death, all-cause mortality, and fatal as well as non-fatal stroke. What it showed is that the 4-point MACE was significantly reduced, 3-point MACE was significantly reduced, non-fatal MI and coronary revascularization was also reduced in the bempedoic acid arm. And amongst these statin intolerant patients, treatment with bempedoic acid was associated with the lower risk of 4-point MACE by 13%, 3-point MACE by 15%, risk of myocardial infarction by 23%, and coronary revascularization by 19%. See, coronary revascularization has been so far, the Achilles heel for angioplasty. Why bypass is superior at times than the angioplasty? Simply because the repeat revascularization is less. But if we have the drugs with which we can reduce as much as 20%, why not? That's the best way. Apart from these, the certain effect we talk about, the pleiotropic effects of statin, like reduction of HSCRP, we have seen beautifully in a Jupiter trial, that is still been exist, and it happens with this also. Almost 22.2% of HSCRP reduction was noted in the trial. And then comes to the safety. We have seen efficacy part. Now we have to see the safety part. So adverse events were comparable to the placebo, leading to the discontinuation. Myalgias are lesser than the placebo also. Discontinuations were lesser. Diabetes, no issues. Renal impairment, not much of issues. Minor issues were hyperuricemia and gout. These were the big cause of concerns. And that's why the clear outcome study concluded that bempedoic acid becomes the first ACL inhibitor and the first oral non-statin to demonstrate statistically significant reduction in MACE in patients with or who are at a high risk of cardiovascular disease with documented statin intolerance or elevated statin or LDL-C in spite of statins. So we were so far used to say that there is nothing like statin and no one can replace. So this is a drug which has definitely shown the similar outcomes. And that's why it's well tolerated. We have seen as compared to the placebo, not much of things. HSCRP and LDL-C reduction, that's what we know. So it's efficacious. Obviously, small increase in the incidence of gout and cholelithiasis or uric acid. Primary and secondary efficacy point like 3-point MACE, 4-point RACE, myocardial infarction, revascularization, everything was shown to be important and significantly reduced. And that's how bempedoic acid is an effective approach to reduce major cardiovascular events in statin intolerant patients. So thank you all for a patient listening. In last 15 or 20 minutes, concise, I tried to give you the outcome data and few of the insights about the bempedoic acid. I'm very sure that most of us are using it in our practice, and now we have got a reasonable confidence to use it. So if there are any day-to-day questions or is there any doubts if someone has, I think it's a worth discussing because it's a new molecule and we all can learn from each other.
Thank you so much, sir. Such a lucid presentation it was and up to the point. There's one question which has come. Dr. Shetty is asking about in diabetic patient how safe bempedoic acid is.
Yeah, as we saw the one of the slides which clearly mentioned that when we were talking about the safety part, that it has not any interference much with the diabetes or diabetes control. Like in statin, we say that, okay, it increases the incidence of new onset diabetes. So that issue was not much found with this, right? Maybe we have to wait for the more larger data, but at least statin with it was well proven, while here it is not been proven. So we assume that it is not or it is a safe with the statin.
Thank you so much, sir. The next question is about, initially you mentioned about 2019 guidelines. They are getting stricter and stricter. And related to that, the question is how low one can go down for LDL cholesterol?
Okay.
And is it safe? Any neurological complications one patient can
Yeah,
have?
not much of neurological complications, and it can be as safe as low as 15. So I'll tell you a story about it. So how this PCSK9 came into the picture. There was a gym instructor lady in US with proper 3 kids, and she was a gym instructor, daily used to go and teach and do the self thing. And one fine day, she got a lipid profile done and the LDL was showing 13. Again repeated, it was showing 18. So the thing was like shaken. How so low LDL is possible? And that started the investigation, and ultimately turned out that she has having a PCSK9 receptor deficiency. And that proved to the world that, okay, if you knock out this PCSK9, still it is safe. It can reduce the LDL. And if she can have 3 children, why others cannot have? And her LDL was 15 average. So that led to the discovery by, Amgen about this allokirimab and everything. And then the PCSK9 came into the picture. So it's very safe. Second thing is about the infants. When a human infant is born, the average LDL is around 30. So if they can grow, their brain can develop, their muscles, hormones, everything can develop. We are all grown up who are a potential of dying of coronary artery disease. So it's all safe. And that has not been proven. There was one small study about increased incidences of intracranial hemorrhage on statins or high dose statin, but that was in mice. It was not proven in humans. So that's why so far we take it as a safe. And now in our own experience, we have seen statin use since last 2.5 decades. We haven't seen ICH because of statins. So I don't think that a lower LDL can precipitate the statin. And now few of us who are using PCSK9, we commonly see the LDL is 15, 25. Initial, when we were part of the principal investigator, moment that used to go down to 30, we used to reduce the dose because no one was knowing what is happening. Then later on, the instruction came that, okay, don't reduce anything, just continue. So some of the patients were maintained at 15, and we followed them up for almost 4 to 5 years. And they were all fine. In fact, there were no MACE. Even post-CABG patients, post-plasty patients, there were no MACE. So I was like totally impressed with PCSK9 and their efficacy. But issue is the cost. It's like per day, 1,000 rupees cost, and for indefinite, we can't give. And that's why we search for these newer and better options. And that's how bempedoic acid comes into the picture. There are 3-4 statin naive patients where we have prescribed it. They're tolerating it quite well, and they're happy about bempedoic acid.
It was a wonderful story, sir, to hear from you talking about how low one can go about LDL cholesterol. And the next question is about my patient is having diabetes, and then he's also hypertensive. What LDL cholesterol goal should I target this patient? There's no much information available, but this is what the question is.
Okay, I think, yeah, the information given is incomplete. In the literature, everything is available. because there are scores, right? ACVS score. If we just feed his date, date of birth or age, he's already diabetic, hypertensive, and then high LDL. Rest of the parameters like smoking and HDL, and if you feel, you will get a data whether he is at a moderate, high, or low risk for having a ACS. Anyone having a more than 10-year risk of more than 10% deserves a high intensity statin. Anyone who has had a myocardial infarction, anyone who had a ischemic stroke, anyone has a documented peripheral arterial disease, irrespective of their diabetes and hypertension status, is a high risk patient. And straightaway recommendation of both the guidelines, or three guidelines, will say ACCHA, ESC, and LI, that is Indian Lipid Association guidelines, says you should give high intensity statin. Now, high intensity means 40 or 80 of atorvastatin or 20 or 40 of rosuvastatin. That is high intensity. Or you should try to reduce LDL more than 50% from where you begin. That is the definition of high intensity statin.
Superb, sir. And as you brought out this topic of like how one can use the apps which are different available, which can guide the risk probability of the patients. Any recommendation you are having, or how one
As
can
of now, we are happy with the ACS score, which is freely available on the Google. Other one is a Framingham risk score. So see, these things are very well, validated. It's like Framingham now, third, fourth generation data will be published. It's like it's the longest study in the history, going on more than 55 years now. So whatever it comes out of that data is definitely trustworthy. So Framingham risk score is available on Google, and ACVS score is available on Google. So we can just fill in the blanks and get the answer.
Fine, sir. The next question is about how you define patient is having statin intolerance. Like how you come to know that patient is having statin intolerance. Any clinical judgment or any blood checkup or anything which you do that makes sure that patient is having statin intolerance.
Okay. See, most of the time, if we see the statin intolerance, we even consider myalgia. If we see myopathy, the incidences are very low. It's like 1 in 1 lakh or so. But intolerance is something where we take key, okay, if he's not tolerating it, let's take out. So that is what is very subjective definition. Now, how are we differentiate between myopathy and myalgia? So myalgia is totally subjective. If patient says, I am having pain in exercise and my muscles are aching and everything, we have to take it literally for the sense of it. And then manage it. If suppose there is a elevation of CK levels, then it adds to the credibility that, okay, muscle enzymes are elevated. That means these things are having the problem. And then comes that, can we declare him that now he's statin intolerant and we can't give? So if we have tried 2 statins in the optimal doses, if he's not tolerating, then we can just declare that he's intolerant to the statin, right? Statin intolerant, that you can't, later on give him again any other statin. If you have tried 2, if he's not tolerating one, probably he may tolerate other, because the statins, though they are similar group, but they are slightly differently metabolized by different CYP enzymes. And that's why those who don't tolerate atorva can sometimes rosua, and rosua not. Generally, pitavastatin is the best tolerated statin known for, but it's a moderate intensity statin. When you have to have a intensity or high intensity, then pitavastatin is not a great drug.
Thank you, sir. And there is the last question from our end is, what do you weight more, LDL cholesterol or triglycerides?
What do you
weigh more, LDL cholesterol or triglycerides? Because many times triglycerides on higher side, like 3,000, 5,000, 4,000. So, which is very important.
See, the primary goal of treatment is always the LDL, which has been already defined and proven in all the trials. When the first trial started was a 4S trial with the simvastatin, where the limit was patient with ACS less than 160 and more than 160. Thus, the LDL getting down to 160 helps or not. And still that showed 23% risk reduction. So there we started chasing this LDL from 160. Now we are getting it to less than 30 also, or probably we are eyeing less than 55. So that much journey we have done in last 2.5 decade. So that shows that this is the primary target. While this much of causal association has not been proven with triglycerides. So that's why we label it as a secondary target, either a non-HDL-C or a triglyceride. These are the second target. If you have well achieved LDL and still TG is high, then okay, I might chase it for the safety of the patient. But most of the time achieving LDL itself is like a big thing. So for me, it's a LDL.
Thank you so much, sir. It was wonderful having you on board today evening, talking about clear outcome trial, and of course clearing all our doubts on bempedoic acid. This is a late-breaking clear outcome trial which was presented in ACC, American College of Cardiology, which you presented very well, up to the point, very lucid presentation it was. And thank you so much for being with us on this today evening. I thank all the delegates for being with us and clearing all our doubts, asking questions time again and again, and clearing our doubts about bempedoic acid. And thank you so much, sir, for having you once again. From Zydus Life Sciences, we'd like to thank and sincere gratitude towards having you on this board, and then thanking all the delegates once again. Have a good night, and take care of yourself. Thank you very much. Thank you, sir.